Welcome to Epi Research Seminar. It's really nice to see you this morning. Today we have a special guest, yet another person that was recommended to us by someone in the audience. Epi, I always say Epi Seminar runs on you. So thank you for all your great suggestions. We've had a real incredible lineup this year. So I'd like to introduce Dr. Wendy St. Peter, who is a professor in the College of Pharmacy here at the University of Minnesota. And her career has really focused on improving medication management and drug safety in patients with kidney disease. You also have worked as a pharmacist, which is really cool. When I was an investigator at VA, my office was right next door to a pharmacoepidemiologist investigator, and like really for him, because I think pharmacists are so interesting. And I just always I feel like you can ask the pharmacist any question in the world and they know so much. And I was always just like, and then what happens if you eat a grapefruit on top of that? So I'm going to exercise some self-restraint when we get to question time, but none of you need to do that. Dr. St. Peter has done a ton of interesting things. I don't know if you'll have a chance to talk about this, but one of the things that you've done and kind of are doing is leading some of the work in race-free EGFR medication decisions. So really super interesting area. And you're currently the director of the National Advanced Kidney Health through Optimal Medication Management Initiative. So thank you so much for coming to visit us. I have a special thank you gift for being an Epi Seminar speaker. It's a W. Bob souvenir.
Love building.
So I'll hand it over to you. Thank you so much.
Well, thank you for that kind introduction. Usually you don't get the gift until afterwards when you see if they've done a decent job. You can always put it under the table.
Well, some people I do wait. I got a good feeling about you though.
Thank you. I'm very excited to present. I understand we've got a variety of people in the room today, first year graduate students up to third year graduate students and faculty. Is there somebody I missed?
Some staff.
Staff, excellent. Well, I'm very excited and honored to be here today. As an introduction, as I've had kind of an interesting pathway, and I'm just going to describe that very quickly, that I did start out as a clinical pharmacist at Hennepin County Medical Center, where I worked with a medical team, a large team with a large population of patients with kidney disease and many on dialysis or peritoneal dialysis. And so about 10 years after I was working as a clinical pharmacist, one of the physicians, Al Collins, who I worked with very closely clinically, gained an NIH contract for what is the United States Renal Data Systems, which is a data registry using Medicare data. The reason why Medicare, who generally covers patients that are greater than 65, those are disabled end-stage kidney disease program, also is covered. So we had a lot of information, and Dr. Collins, was with the team, was instrumental in gaining that really large NIH contract to look at the epidemiology, and he brought me in with my clinical expertise for the pharmacoepidemiology part of that. And what was interesting is I had absolutely no epidemiology background. And so I was put in charge of a team who were mainly biostatisticians and analysts. And I recognized after about 2 or 3 years that I just felt like I didn't have enough expertise to be able to talk, in the same language with the people I was working with. And so I took a sabbatical for a year, classes here at the School of Public Health, as well as at the University of Michigan, and that really helped me. So I don't consider myself a pharmacoepidemiologist. I haven't been trained for a number of years in epidemiology, but I've gained a lot of knowledge just by working with the teams over the years. So that's what that's about. So today, what I'm going to talk about is, this intersection, what is pharmacoepidemiology? Give you some examples from either work that I've done with my group or work that an undergraduate student has just recently completed in his dissertation. So the intersection between, pharmacoepidemiology is really the intersection between clinical pharmacology and epidemiology. So in clinical pharmacology, what is done there? Well, that's the study of how drugs affect the body, how they're being used, side effects, beneficial effects, in typically in individual patients, and then sometimes in population. And pharmacoepidemiology is really that study in populations. But where do we draw from? It's really, we use the tools of epidemiology to study drugs, drug use, drug safety in big populations. So without those tools of epidemiology, we wouldn't have pharmacoepidemiology. The International Society of Pharmacoepidemiology describes, very scientifically, as pharmacoepi is a scientific discipline that uses epi methods, value, use, benefits, risk of medical products that contain drugs. So when I talk about medical products, I talk about drugs, of course, but drugs that might be in drug-eluting stents. So there's drugs-related things, blood glucose monitoring for diabetes drugs, those sorts of things. So interventions in populations. But, frankly, I like the patient-centric definition of pharmacoepidemiology. It's really just a study of use effects of drugs in large numbers of people, populations. So what I thought I'd do and start with this, when we take this pharmacology knowledge that we get, what is done with that and how does it move into clinical trials and how did we get to pharmacoepidemiology? Well, when drugs are first studied, they're usually studied in animals. And then in an animal, for instance, in a diabetic rat, you expose that rat to different drug substances. And if you see positive effects, either with efficacy and little safety effects, then it goes into the next stage. And this is a stage of clinical development. Have you learned about these stages? Okay, first year students, everybody's nodding. Has anybody not heard about it and understand what these are? Okay, a couple. So I'm going to quickly go through. So it goes on to phase one if it looks good. And phase one is you take healthy individuals, you expose them to a drug. It's a drug looking for drug dose effect, and it's a very short-term study. So they're looking mainly for, big safety issues, not efficacy issues. So if it still looks good, it's safe for phase one, goes to phase two, and those studies are typically in 100, maybe less, depending on rare disease, up to maybe 900 to 1,000 patients. Phase two is in sick individuals, okay, and short term, and they're looking, again, mainly for safety, but also efficacy in that part of phase two. So all looks good in terms of efficacy and safety. It goes on to phase three, and that is large scale randomized clinical control studies in large number of patients. For instance, some of our blood pressure trials, how big are those? Anybody familiar with some of the major blood pressure trials in the US? Pam, are you familiar?
5,000.
I'm going to point to her. I know she does pharmacoepi. 5,000 up to 9,000 in some of these big cardiovascular trials. And so these are looking over a more diverse group of people, larger populations across the US. And then if everything looks good, these are longer term studies, oftentimes up to about 3 years. In phase three, they get drug approval. FDA says, yes, Food and Drug Administration, and then there are sometimes phase 4 studies, and this is post-marketing now, so the drug's on the market. In case there are safety signals or concerns, let's say in case of you've got a drug class where some drugs have shown safety signals, then you might want to extend to post-marketing surveillance with another drug that might be in the class that might have the same effects. That was true of, SGLT2 inhibitors. You can't miss them. They're advertised every 5 minutes. Seems like Giardians and Pavlofloxacin. Well, the first drug that was on the market, Nagliflozin, had some safety signals for fractures. And therefore, the FDA required subsequent studies to look at fractures, and they're also, looking at them through post-marketing surveillance studies, but they're not always required. So then, what are the limitations of phase 1 through 3 marketing studies? Well, you see in the left-hand side, not like randomized controlled trials are cookie cutters, but approaches, not exactly the same people. So they, especially in the large trials, you try to get a broad range of person types. But the sad truth, even up to today, is that they're largely in the United States white, although that's changing now in some of the where they're deliberately, making sure that they're capturing other race ethnicity groups. They don't all, usually don't enroll frail elderly, maybe people that are extremely obese. They just don't get the major diversity that happens when those drugs are released on the market, and then they're given to anybody, right? The doctor can prescribe those drugs to anybody, not necessarily those that are in clinical trials. So study subjects in the studies, we know they receive good care. They're monitored frequently, and they're checked, which doesn't happen all the time in real life. And so there's kind of this healthy user that they're making it, keeping them, they're detecting things, which isn't happening routinely. And there's shorter duration of treatments in these studies. And oftentimes some of these drugs that have effects on more than maybe the intended piece, like I'm going to give you an example. I've got in anemia, patients with kidney disease have anemia, and there's a new drug on the market that are HIF inhibitors, hypoxia-inducible factors. And what they do is they not only affect the system, the red blood cell system, they affect multiple cells in the body. So when those were released, there was major concern that it would long-term affect other cell lines in the body. And so there's been a lot of observational, retrospective, non-randomized control studies looking at that. And the study sizes, of course, can be much greater. So the evolution of pharmacoepidemiology really started kind of with the Kiefer-Harris Amendment of the Food, Drug, and Cosmetic Act. And it really started that formal safety studies, looking at drugs in new drug applications. So it's not about efficacy. They started with FDA, with their approval process, with safety as well. In the 60s, a lot of health systems, particularly hospitals, were doing drug use evaluation. In fact, that was my first job I had when I was in graduate school with my PharmD program. Worked at a women's hospital. I was in charge of looking at how drugs in pregnancy were being utilized in the hospital, and making sure they were going to the right persons, and that we were making sure that the right persons actually got the drug. And those are now done throughout health systems, but it's just really a description. And then in the 70s, we had the Drug Epidemiology Unit in Boston. It's now the Sloan something center. I can't remember the second name, but they started collecting data from patients about side effects of the drug. And they found, drug history exposures that related to that. It was really our first post-marketing surveillance safety. And then Compass, this was huge because this was a computerized online Medicaid analysis and surveillance system. It really used Medicaid. Now, what is Medicaid? What is Medicaid? Does anybody know? Know about Medicare, but Medicaid is a federally funded and state funded insurance. It's really unique to each state because they use their money sometimes in different ways, but they cover patients that, can't afford health insurance, have low income, those sorts of things. So they started using Medicaid billing data, not EHR data, from the medical records, but billing data to look at various drugs using pharmacoepidemiology. And then in the 2000s, we had the FDA REMS program. That's the Risk Evaluation Mitigation Strategies program. And that really was an offshoot. Do you remember the thalidomide crisis? You've been taught about that, and really came about because of that. So they needed to do safety surveillance on drugs, and while these drugs were being, after they were marketed. Side Network, which I was really lucky with Johns Hopkins with a contract with them to look at blood pressure in patients with dialysis and do some analysis there for safety and efficacy. The FDA Sentinel Initiative, have you heard about that? The Food and Drug Administration. So this was an idea, concept kind of that was built from, the REMS program, but also the FDA had, it's called the FAR system. So it's the FDA Adverse Drug Event Reporting System. So if somebody goes in, gets a drug, they get side effects, they can send in this form for physicians or nurses or pharmacists, but you don't have a denominator, and you know what a denominator is right now, don't you? So people that are having side effects, these are voluntary applications, but there's no denominator. And so the FDA decided on the Sentinel Initiative, and it was really using data from healthcare systems, insurance companies to do some safety monitoring. And what spurred that was a drug, dabigatran. Have you heard of that one? That is a drug that is a blood thinner. And they were monitoring it when it came on the market, and the REMS, or not the REMS program, but the FAR system said, oh gosh, we're seeing a lot of bleeding in patients. That's worrisome. So they used the Sentinel Initiative on data. They looked to see and compared it against the standard blood thinner, which was warfarin at the time. And they showed that it didn't have any more bleeding risk than warfarin did. And so this was kind of the launch of that. Now we've got, big agencies like the Patient-Centered Outcomes Research Institute that is funding studies in the pharmacoepi area and funds research, also randomized controlled trials now too, but really was first centered on those kind of the pharmacoepi compared to the effectiveness studies. Then FDA continued to grow its system to where it is now, the Sentinel system. So they've got 13 data partners currently, huge data partners, some in our neighborhood. So Optum Health Partners Institute, Marshfield Clinics, which is in Wisconsin, all's there, that are part of that drug surveillance system. So they've got hospital EHR data, electronic health records, plus claims data, insurance data that they mingle. And now they've got, data on actually more than 4 million patients, but 200 million patients that have at least 2 years worth of data. So this is a really exciting progress where we can look at things. This is where we're talking about epidemiology, pharmacoepi at its best, these huge databases, putting both electronic health records plus claims data together. So what has been the contributions of pharmacoepi? Well, it's real world. it's like when those drugs get out there, we're studying in a real population of patients that are actually taking it. You've got higher precision, right? It's got more patients you're looking at, far more than you do in a clinical trial. We include patients that haven't been studied before. And what is really nice is, unlike the randomized controlled studies, we can look at things that interact or modify the effect of associations we're looking for, other drugs that the patient may be taking, other diseases and conditions that they have. And then we can use it, like with picori, to compare drugs, use for the same indication. So really, pharmacoepi provides a lot of information out there, not only, for health systems, for government policy related things. It's really drug coverage policy. It generates that real world data that now drug manufacturers are required to submit through, basically for PBMs or for, other healthcare systems who may want to use these drugs to submit before those drugs are put on formularies. So oftentimes they want to know what is happening with that drug in your health system, what is some of the data. So these dossiers are really important sometimes for these big healthcare systems and PBMs to put the drugs on formulary. So I'm going to stop there for a second just to see if there's any questions or any comments. Or Pam, if you have any experience that you might want to add in. Nope. Yeah.
So how often does a drug get to phase 3 and then never show up? Is that a?
I just thought, it's
would a
funny.
company ever pay that amount of money to get to that point and then fail?
Oh, yeah. Phase 2 for sure. Phase 3 is less likely, but again, with phase 2, you're only talking about, sometimes with rare drugs, especially 50 patients, up to maybe 900. So yeah, I do a feed every day on, industry and pharma to see, and I'm always surprised. So-and-so just shut down the study because it showed too many side effects in a cancer population, for instance. I just saw one about that the other day. So it's really, of course, pharmaceutical companies cringe when that happens because they've already invested millions and millions of dollars on research when it gets to stage or phase 3. But yeah, they don't want to go any further because it's even more expensive. Or something else comes on, there's another drug that comes on, and they're like, well, we can't compare to that, so they'll shut it down.
Or Cetrafit.
Hmm?
Or Cetrafit.
Yeah. Oh, yeah. Go ahead and share.
Want me to do it?
Absolutely. Where's that microphone?
I don't need it.
Better way. If I had a microphone, I'd be over there.
So the interesting thing about torcetrapib is that it's a CETP, is it? CETP, cholesterol or ester transfer protein drug. It raised the Dickens out of HDL cholesterol, went from 40 to 60, and $800 million later, when it was discovered at the same time that it was actually causing harm, the trial was taken down. And the interesting thing that happened is that the pharmaceutical houses, instead of entirely giving up on CETP inhibitors, actually has invested in additional CETP inhibitors, and they found some that don't have some of the side effects. But I don't think they found any that's beneficial.
You're surprised they've gone down that pathway, right?
I am really surprised, but the whole HDL story is really interesting. And so that's one of the primary ones I think of when I think of phase 3 and then failure.
Yeah, I think that, oh, go ahead, Pam.
Oh, no, I was just gonna give a different example.
Oh, give us an example, go ahead.
Fen was a weight loss drug that, nowadays it's all the GLP-1 and GIP inhibitors. And Fen was pulled off the market after it was approved because of pulmonary hypertension, particularly in
valvular disease, yeah. My husband, John St. Peter, he's not here today, but he is one of the key, he was on that article, probably did the key research that was needed to demonstrate that. Really good example. So yeah, and actually these studies do have data safety monitoring committees. And so oftentimes in these longer phase 3 studies especially, they will look at the data intermittently, one for efficacy, if there's not, and two, they'll look at it for safety. So it's the data safety monitoring committees on these big trials that will say, you know, we're just not seeing enough effect of this drug, and we're seeing a terrible safety signal, so we've got to shut down the trial. So it happens oftentimes in the midst of the trial because of the data safety monitoring. Yeah.
Would you consider vaccine development part of pharmacoepidemiology, or is that sort of its own?
Well, it's a biologic, yes, it is pharmaco, you know, I consider vaccines as a preventative therapy. Yeah, I would include them in the pharmacoepi population health area. Yeah.
Maybe you want to mention emergency use authorization, how that circumvent this a little bit, the process.
Oh, yeah, so, you know, when COVID was happening and we were working on vaccines, and we found some vaccines that looked efficacious, and at that point, you know, with limited number of people that were studied, looked safe. The FDA gave an emergency, EMA, emergency medicine, what is it?
Emergency use authorization.
Use authorization, sorry, I was like, oh, I got my initials all mixed up, and allowed those vaccines to be used, even though they hadn't gone through every single stage and large number of patients in through the FDA standard approval process. And of course, now we know those vaccines have been approved in numerous patients at this time as being safe and effective, but you're right. And it was an emergency, and it was good that they did that so we could demonstrate. And we found that, you know, efficacious and safe. So anything else? So now I'm going to turn to the experimental versus observational studies. So you've heard of the randomized control studies, that's experimental. The researcher takes a group of patients, says, we're going to give you that drug, we're going to give you a placebo, and then we're going to look to see what effect it is. That's generally what is being done in the FDA approval process. Drugs are being compared to placebos, not a comparator drug. And so you've got both experimental and observational. Pharmacoepi fits in the observational study space. So the research studies, but does not alter, meaning they don't intervene. Patients got started on a medication, they don't start them on the medication. So we find those patients who are started on the medication, and then we start our evaluation of what happens to that patient. So with pharmacoepidemiology studies, some of the study designs that fall into space are ecologic studies, case control, which I won't go over today. I'm sure you've talked about case control designs, right? Have you talked about ecologic studies? Okay, so you know about those cross-sectional studies. I won't talk about the cohort studies. I'll address a little bit. So you've got your descriptive designs, descriptions of what has occurred, you know, under your research designs. They include things like case reports, case series, which I don't consider either of those to be pharmacoepi study designs. I think there's some gray area with the case series, but ecologic studies certainly are. You're looking at trends over time and trying to find an association between one trend and another, and I'll show that in a moment. But then there's inferential designs. We ask a question, a hypothesis, to compare difference between, you know, either naturally occurring or in a randomized control study and actively manipulated is really a bad term, isn't it? Should put intervention groups. I'm going to change that word after this presentation. Anyways, we don't manipulate things. That's a bad way to state it. So cohort studies, case control studies fit into that inferential design. You ask that question, as do randomized control studies. So with descriptive designs, you already know this. Basically, there's studies that simply they describe trends. Those are ecologic studies that, fit into these. We've done a lot of trend analysis with the United States Renal Data Systems. We've got an annual data report, and my job is to look at trends in drug use, drug cost in different, groups of people, race, age, sex, across time. That's drug use trends. And then typical simple descriptive statistics are used to describe the data. So let's go over one that I was involved in. It's quite a number of years ago, but I think this is a really was an interesting study in that this is the first time I did an ecologic study. So this was looking at hemodialysis patients. And hemodialysis patients, because of the multitudes of physiologic changes in their body, their parathyroid hormone levels typically go up, which break up people's bones. They tend to have this problem with breaking bones. And you could see that over the years from 1992 in the Medicare database, you see this huge rate of climb. And then all of a sudden, around 2006, 5, you see this major change in hip fracture rate. And of course, we did this study first just to look at hip fractures, like, wow, what caused that? And so that was a trend analysis, a descriptive analysis. I'm going to just show you these lines are the lines. So I'm going to use this in the next graph where, the trends are going down for hip fracture rate. Now we also, because they have bone and mineral disease and there's different things that influence that, we're looking at vitamin D use, not specific individuals, but across the whole population, and different vitamin D uses. So you see these curves up here. These are representative of different types of vitamin D. And the first one that you see, I'm going to come out here just to show you. You see it going up. That's calcitriol. It's an activated vitamin D. The kidney activates vitamin D in you and me. Dialysis patients' kidneys don't work, so it's not activated. So you see the trends going up. Oops, I need to do one more. Sorry. You see that it's going up, and then you've got newer agents coming in, the dashed line and the one with the black boxes. They're coming into play because they have less calcium absorption, so less problems with hypercalcemia. So you saw those just go up. But you notice that the vitamin D analogs didn't seem to really occur. That big upward swing didn't have any, what we don't think, an association with the downward trend in hip fractures that happened during the red lines there. So what else happened? Well, we had a number of phosphate binders on the market. That wasn't doing any effect in hip fracture rate. In fact, the hip fracture rates were going up with calcium containing phosphate binders. Phosphate binders are given to dialysis patients to absorb phosphorus in their food because their kidneys can't reduce phosphorus. And phosphorus plays a role in this bone disease that patients have. During this set of lines here, what happened? Well, a new phosphate binder came on the market. It was not calcium containing. There was one coming in later on that was not calcium containing, but the trend down already was starting before those two were introduced on the market, and lanthanum wasn't used very much. What happened? Cinacalcet. Remember I told you PTH breaks down bones. Cinacalcet reduces parathyroid hormone, and it seemed to be related to cinacalcet administration. There was also guidelines that came into play in about the same time frame here in 2003, and then another version of non-calcium based phosphate binder. So cinacalcet, guidelines, another non-calcium containing phosphate binder. So what do you think? What do you think made that trend, or what do you think? Was most likely? Was it guidelines? Why not? There's guidelines for bone disease mineral management in this patient population. How long do guidelines take to go into effect? Any guideline that you put out there from a public source. These are major national guidelines. How long does it take a practitioner to respond? Yeah, decades. So it probably wasn't due to the guidelines. And it wasn't due, looking at the phosphate binders and the fact that this one was coming in about the right time, that wasn't being used very much, so it wasn't impacting. So our thoughts were it was cinecalcet. And indeed, we did a follow-up cohort study on that to demonstrate that cinecalcet did decrease hip fractures, and cinecalcet is, and one of the analogs is used routinely in a lot of dialysis patients. So the question is, the trends in hip fracture and the trends I'm showing here, are these causal relationships? So there was a trend across a population in hip fractures. There's a trend in the populations, same group of patients. We had no dose effect or anything, but the trends in use across that population. So is that a causal association?
Maybe.
It could be hypothesis. More of a hypothesis, right? And especially with the thing that we thought might have been the biggest thing to cause effect, that cinecalcet, we had no information on it at all. We just had information on when those things came onto the market. So this was hypothesis generating. There's no causal association. We're just looking at, association and trends. There was no, we didn't have a question, pre-thought about a hypothesis that cinecalcet would reduce this. We did that in the next studies where we had a hypothesis generating study. So these inferential designs, the cohort studies I'm talking about, we have, again, no active intervention. We're not giving patients drugs. We're just seeing if they take them. And we're using now statistical techniques, advanced modeling, things like Cox regression, Anderson-Gill model, lots of different matching techniques, which I'll talk about, to try to reduce the differences you see in these sometimes disparate populations of patients that are not getting drugs and those that are, or even between comparative groups of patients who may be taking different drugs. So just again, remember ecologic here. See on the left-hand side, the exposure is known at a population level. For instance, sevelamer use as an exposure. You notice that as that increased, mortality also decreased. Calcium channel blocker, which is kind of a comparator, one that was on the market first, its exposure decreased through that same time frame and mortality decreased. So we're talking about now two other drugs, and this time effect on mortality in dialysis patients. So this is exposure at a population level, but in a cohort study, and this is another, set of analysis we did a look at sevelamer, which non-calcium containing, which, was thought that over time with exposures to large amounts of calcium that could cause calcification in patients' vessels. In fact, a lot of dialysis patients have calcified plaques in their vessels. So in the cohort study, we do know the exposure at the individual level. We know that patients taking the drug, we can identify it. And we looked at sevelamer versus calcium channel blockers. And then we looked to see if it was associated with mortality outcome. This is a study we published back in 2014. Again, in dialysis patients using that USRDS Medicare data, and looked at Medicare enrolled patients that were on hemodialysis. And we looked at a number of different outcomes, but our primary outcome was really all-cause cardiovascular related mortality. So this is how we designed our methods, much more intense than just a descriptive trend analysis. We had a population that we identified prospectively. We didn't have any intervention, but we were comparing patients that were started on dialysis and newly initiated. So this is a new user, we call this effect, either sevelamer or calcium acetate. And then we used various methods. It was, one group versus another, all the patients in that group that fit the criteria. But then we used a statistical adjustment using tons of different potential confounders and that we thought could be affecting the outcome of mortality. There's a lot of things that could affect mortality in patients that are dialysis. And then we did a propensity score method. Have you learned about propensity score methods? Good. I'll explain that. So this is a busy slide, but I'm just showing you the main cohort. That was unmatched cohorts on the left. The propensity score cohort, the green one, is on the right. And I just picked out one number. This was the use of vitamin D, because we know that vitamin D can be influential in bone health and potentially in mortality. So, we had almost a 15% difference in use of vitamin D and a 1.6%. The standardized median difference, which is really the difference between the two populations of patients. So you use that. Do you know why you use the standardized mean difference instead of just doing like a p-test for statistical significance value? Anybody? Faculty? No, I'm not gonna compact. Okay, so you use, lots of times you'll see these baseline tables. This is really important now in pharmacoepidemiology. You look at the baseline characteristics because you want your patients to look the same, be the same as possible. The standardized mean difference gives you the difference between the two groups, means that in a measure that is unrelated to the sample size of the population. So it can be used in small studies and large studies. Typically, p-values are going to be always significant in populations, even if there's just a tiny clinical difference between patients, because there's such a large sample and the precision is better. So this is just a method that we use now to look at differences, and typically you want it less than 10%. You can see in the standardized column when we did that propensity score matching, it was reduced. And then you see what happened. This was unmatched mortality results. No difference between the two. The other one with propensity score match, there was a modest, the hazard rate was 0.9 for a modest reduction. And we're like, not a big reduction. It's most likely not true, but then we went on to do some sensitivity analysis, which you do to make sure that these findings are robust to different evaluations. And we did an analysis that essentially looked at patients that were adherent versus those that weren't adherent. We know how often they were filling their prescriptions. And so what we found, interestingly, is that our hypotheses are, if somebody is really adherent to their calcium-containing binders, that would put a lot of calcium in their system. That should actually cause them to potentially have a higher mortality rate because of buildup of calcium. We didn't see that. In fact, in both groups, adherent groups, both did better, statistically different, better than non-adherent groups. And so it just told us that the patients that were taking those drugs are probably healthier, patients that were more involved in their health care for one reason or another, they were adhered to their medications. So we basically said in the manuscript that we don't think there was really an effect. Now, this was great. This was great for me as a younger investigator because the randomized controlled trial said it was different. It was the largest randomized controlled study in the history of dialysis patients. And the study had some problems in terms of people switching phosphate binders in the middle of the study because everybody wanted to be on spalmer, not calcium containing. But their study, the primary evaluation was mortality. There's no difference in mortality in the overall population, but they said in 65-year-olds and greater, there was a significant difference. That caused an outcry, which caused us to do our analysis. And this analysis actually went into the KDIGO guidelines. These are international guidelines showing a higher strength of evidence than that randomized control study did. That was cool for me as a younger investigator. So lastly, I'm going to leave some time. Have you heard of target trial emulation? Then do you know? It's a technique now used in observational studies. It's kind of this hot new fad. Because we were doing target trial emulation in our pharmacoepi studies before that even became a word, way back when. But the whole idea is that you have to, just like you would do in a clinical trial, you state a hypothesis. You've got a primary outcome. You set up a whole protocol that you would set up for a randomized controlled study to get the perfect patient population to study. Then you try to emulate that in your observational data. I'm going to just show you quickly. This is my graduate student, Sam Su, who is now in a postdoc position over at UPenn. He looking at the effect of discharge opioid amounts, so a high dose versus low dose, on use of opioid, on opioid use disorder within 2 years. And so he did on the middle column, he gave his hypothetical randomized controlled trial, and then he showed using, this was Fairview data here at the University of Minnesota, emulation in the EHR. So as best as possible, he tried to emulate what he put down was his randomized controlled trial methodology. So I'm not going to give you the whole thing. But basically, when he came out, his outcomes showed that there was a high relative risk, so an increased risk, about 66% increased risk for 2-year opioid disorder. That means over a 2-year period of time. And he evaluated, again, a number of sensitivity effect modifications, looked especially between minor and major surgeries, and found that it didn't matter. High doses of opioids was associated, strongly associated with opioid use disorder within 2 years. And then he did one of the sensitivity analysis, just looking at different cut points and the morphine equivalent, the high MMEs, which is morphine equivalent doses essentially for different opioids, and saw what you would like to see a dose related effect. So the higher discharge amount of opioids, the higher the risk of opioid use disorder in 2 years. So these were in opioid naive patients. So he's on the cusp of publishing this data. Lastly, I wanted to talk, why do you want to go into this? All of you in this room, faculty, Dr. Lutzi, she works in this, and there's a reason, because there's lots of jobs out there. Industry, a number of my students are at high-ranking positions in industry right now, directors, vice presidents of their health HEOR, so health outcomes related research. I'm in an academic institution, so is Pam, so some of us go there. Healthcare systems, this is huge. There are so many big healthcare systems that have ingrained population health units now because they realize they need to do a better job of screening and treating. And so a lot of people are now, and a lot of my good colleagues are in healthcare systems with pharmaco and epidemiologic programs. And then government agencies, Sam, who did this research, is now looking, hopefully, once he gets done with his postdoc position with FDA, so he wants to go into that institution now. I've left a little bit of time for questions about, I can go even after, until 10 after, you probably have something else, but I'm gonna end it there and leave it open for questions, comments.
Thank you so much, Wendy. I want to know how I get a job, coming up with the names for the drugs. I'm just gonna go drugs. So I would be really good at that.
I can't even pronounce some of the new names of these biologic agents. Wow.
Some of them I'm like, oh, I could have done that. Yeah.
So Wendy, thank you for coming. It's always great when you cross paths. And I'm actually talking more about opportunities for people in the room, faculty, staff, students. There's a weekly pharmacoepi meeting that I hold here in WBOB, and if people are interested, you're welcome to attend. We talk about current projects underway. And so that's one thing I wanted to mention. And the second thing I wanted to mention is that Minnesota currently has a license for the market scan data. We're working to renew that. And when I say we, it's actually Joel Farley, who's
One of my colleagues, dear colleagues,
yes, dear colleague to me now as well.
As well, yeah.
We're working toward that. That 7 different PhD students have used those data for an array of projects, being, ecologic, looking at trends, or pharmacoepidemiology or effectiveness. So anyway, if people have interest, you can talk to me later or talk to Wendy.
Yeah, one of my students is using that now for his dissertation work, yeah. That is a great resource, and we have to thank Pam and Joel for working on that, because that is a very broad commercial available. They also have Medicare Advantage information in there, so it's a very nice database. Yeah.
What's your view of the idea of precision medicine or personalized medicine, in which we would generate the evidence base for providers to sort of tailor treatments to the patient, and that that imagine goes both in terms of safety and efficacy?
That's a really good question. I believe in precision medicine. I have a number of colleagues in the College of Pharmacy that are looking at pharmacogenomic data. There are pharmacogenomic units, evaluation units, as well as clinical units within health systems where patients do have their blood drawn. They get their pharmacogenomic data on really some key genetic markers that point to, either having issues with certain drugs where, you give a normal dose and they don't metabolize it, so you get very high levels, or vice versa. They are high metabolizers where you get very low levels. And so it's starting to explain why we see some anomaly side effects in persons you wouldn't expect. And sometimes there's, I would say, ancestry components, so different race groups or ancestry, really the genetic basis of it. So I am in high favor. I think it's moving forward. I think that, I've had my pharmacogenomics panel done, and it's going to be helpful in terms of when you talk to your physicians, you can start on medications when you're getting to an older age or even a younger age, that you hopefully will be put on the right drug at the right dose for you. So I'm highly encouraged by the progress that have been made in different areas. That, yeah, I think it's going to become a component, a routine component, in terms of healthcare.
Time for one more question, if there's another quick question in the audience.
Thank you, Rachel.
Okay, how does aspirin work?
Oh. Wow, the metabolic pathways. If you're using aspirin at your age, there's something wrong, that's all I'm saying.
Well, but thank you so much, Wendy. I really appreciate you coming over for a seminar. If anyone else has a few quick questions, I think Wendy has a little bit of extra time before she has to run off, and I will see all of you next time, hopefully. Thank you so much.